Tim is an associate clinical professor of psychiatry at UCLA, and he's the co-director of the UCLA Gambling Studies program, which is a really important program and one that's unique in many ways. It's devoted to understanding problem gambling, its causes, natural history, cultural factors, and the obstacles to successful treatment. Just a few of the areas that the program works on are understanding neurobiological and societal risk factors, investigating novel approaches to treatment and prevention, and translating treatment from research so that communities can use it and understand it better. Besides all of that, Tim is a wonderful teacher and an exciting presenter. He's a great friend. And Tim, we're looking forward to hearing your insights on mental health, addiction, and COVID-19. So take it away, my friend.
Thank you, Maureen. Thank you, everyone, for coming out on a beautiful fall 2020. This is actually the first time I'll be presenting this material, so bear with me as I think there's a lot of just interesting information here. Again, I've been doing addiction psychiatry now for about 20 years, and our gambling studies program has been on the map since 2005, and it's just wonderful to be working with the council here again. So Maureen and the team asked me to do kind of an update. We've had so much information on COVID and the terms you hear constantly, right? Unprecedented, never seen before. We're all in this together. And instead, I wanted to give a few different perspectives on the impact of how it's impacted us here at UCLA in Los Angeles, and just a few things I've learned from my patients and I've learned from by doing this now 6 months into the pandemic. So a lot of this is, fresh information. A lot of this is going to change quickly over time, and hopefully we'll have plenty of time for Q&A in the chat box. So I really have two main goals here. One is to talk about how we as a country and as a world have seen the impact of COVID in 6 months on mental health, on substance use disorder, and really for us as providers to think about what can we do in 2021 and beyond. What do we need to learn? What do we need to do now so that we can continue to cope with it ourselves, but also help our patients who are struggling with its consequences. And then I'm going to talk about specifically how COVID has impacted gambling disorder treatment in California and what we're doing to take steps to deal with that. So first, let me just start off with, there's so much written out there, and I found this to be pretty timely, but even so, this was written in June 2020, which seems like a lifetime ago. It was 4 months ago, which meant they did the work right when COVID happened in April and May. So even now, a few months later, some of this information may have changed. But it was a national survey conducted out of an academic partnership of North Carolina and Harvard, surveying just 1,500 Americans about how are they dealing with COVID. And you can imagine that, and this will give you some data, half of the population reported at least experiencing significant pandemic-related emotional impact and stress. Anxiety, insomnia, hopelessness, forgetfulness, demoralization. We know that, but to see it in writing is enormous. But even more so, 90% had these impacts almost on a daily basis. So again, men and women were really suffering. The most interesting result is that adults under the age of 50 and people of racial and ethnic minorities, especially Hispanic and Latinx populations, were more disproportionately impacted. Again, this was something I was not prepared for as we started the pandemic, just to see the blast and wide disparity in healthcare impacts, not only physically, but now psychologically and mental health. And again, you hear so much in the news about disproportionate impacted by ethnic minorities on a physical side, but clearly here is starting to show on a psychological side. So here's the experience about what happened at UCLA. And for those of you who haven't been down here, I'm located on the campus of UCLA, where we have our undergraduate campus as well as our medical school and our main flagship hospital, the Ronald Reagan Medical Center. Our UCLA health system has over 7 hospitals, and at any given time has a bed capacity in a couple of thousands for medical and psychiatric beds. So we're enormous. And when this COVID attacked, as Maureen said, early in March 2020, this is what we noticed. Immediately, we transitioned all our outpatient services, mental health and physical, to telehealth. like we all have, even our intensive outpatient programs. But I want to highlight later on about what that was like for me personally. But now, 6 months later, our revenue that our psychiatry department has generated by telehealth is astonishing. We've seen office visits go up by almost 15%. And we've seen monthly revenue now compared to October 2019 or September 2019 is about 25% higher. So what we're seeing is telehealth has just completely revolutionized our ability to provide more care and provide care that's reimbursed by commercial insurance. The questions, though, are how satisfied are patients with telehealth? How satisfied are providers? And what are the quality of care like that being delivered by telehealth? Those are questions that we'll address further on. In the hospital side, where I work a big chunk of the time, we have a 75-bed psychiatric hospital. Immediately in March and April, similar to what happened throughout the nation, our psychiatric hospital, which never goes empty, went down to 25% of its capacity. And then that actually triggered a potential rumor of not only layoffs, but also potentially of shutting down the hospital. However, starting back in May 2020, we were able to go back to full capacity, and we've remained at full capacity since then. But you can imagine the stress that it has on mental health providers, constantly worrying about infections. The patient experience is diminished. They have way less groups, Zoom meetings while they're in the psychiatric hospital, very, very different. And we don't allow COVID patients on the unit. Okay. Now, here's some of the reflections I have in regards to mental health treatment and impact on COVID from, I'll call it the virtual office, because that's essentially what this is. Interestingly enough, the demand for new calls, for new patients, the emphasis I've noticed from most people who are calling is that they want an appointment immediately, within 2 or 3 hours. It used to be people would call, they understood there would be a day to return, then maybe 3 to 5 days wait if you're lucky, usually longer, 7, 14, 21, even a month out before the appointment. Now, there's a press of demand from patients who are like, I'm at home, we know you're available, we know you're doing it virtually, I don't have to travel, I need answers right now. So that brings up a very interesting question of how do we handle that demand for instant appointments. Secondly, I'm not seeing a kind of standard COVID mental health curriculum that's being treated to our patients, whether it be something we teach our med students or our residents or just basic things. And why I bring that up, because I've noticed that for myself in working with clients, that sometimes I'm using the language of trauma with clients, that we're going through a major trauma. Other times with patients, it's the grief counseling model, going through the stages of grief. And for others, it's just supportive. It's miserable situations and dealing with misery through psychosupportive things. So this idea of, could there be some sort of specific guidelines dealing with COVID and its impact on mental health? And I think we need more. And I think we're just at the beginning of that. But I thought that was rather interesting to pull out that different language. So new areas I've noticed in the last 6 months for mental health treatment that I just never really did before, before COVID, was this. How to deal with clients that have massive and multiple losses in a single moment in time and will continue to have continued drains. Now, wait a minute, you say, wait a minute, you work with gamblers. They have massive and multiple losses. True. That's true, but this is not in the lane of addiction. These are in the lane of just men and women who did not have prior addiction or substance use disorder, and now they're faced with a massive and multiple loss. I can understand the massive and multiple loss in gambling disorder because it's from an addiction. I have a harder time personally understand what can I say to someone who's lost tremendous amounts of resources through no fault of their quote own and through no fault of any sort of untreated condition. Secondly, is this concept of demoralization. And again, that word I think is accurate. It's not a symptom, it's not a disease, but it's an emotional state that's painful and that's difficult and that can lead to people suffering. And I think it's important for us to use that language, particularly when it's clear this person does not meet criteria for a full-blown diagnosis. We're all demoralized. We all have trouble sleeping sometimes. We all are just like, really? Another Zoom conference or another lecture today. And I think that's very different than the symptoms that come from depression. The shared hopelessness, I'm finding more times than not, I'm sharing to my patients that I too feel the same sense. And I'm wondering how much disclosure is appropriate, how much disclosure helps with their mental health, how much it may trigger them to know that their psychiatrist and their mental health provider is also going through things as well. And I borrowed a line from the Terminator, and it was very interesting. It's this idea that most of the time in the past, I didn't really talk a lot about the future with patients. We talked about the present and what they needed to do now. But because our own future as a country and as a world, it really is uncertain. And I think this quote, and I saw it the other day in one of my favorite movies, and it makes sense. It says, the future is not set, and it clearly isn't. There is no fate but what we make for ourselves. Now, in the movie, the main actors do all sorts of things to rectify that. But I thought that was very powerful because it really does highlight that our future is not set. We don't know what October 2021 is going to look like. Much of that is out of our control. But there is an element there in that saying that there are things we can do to protect them with whatever sort of things happen in our future. All right, so other things that I'm noticing and encouraging providers to do, instead of saying, oh my gosh, are you depressed or are you having trouble sleeping? We know people are doing, but really focusing on this in the virtual office. And I find that a lot of my sessions now are more about sleep hygiene, that are focusing more about where you're getting sleep, talking about, just their bed, talking about on the nutrition side, what are you or what aren't you putting into your body? I think that's a nice way of highlighting that nutrition equals mental health. Better nutrition, better mental health. Poor nutrition, poor mental health. It's an obvious statement, but it's an area that we all, I think, as mental health providers still need to be going into. Physical activity, and spending a lot of time talking about physical activity with clients, how to get more active, how to reduce resistance on exercise, and how to be safe when gyms aren't closed. Managing screen time is a big portion of the sessions now to impact with COVID and mental health, encouraging people not to just scroll through, as that such a major trigger for mental health. And addressing questions about loneliness, which I think is different than isolation and quarantining. This loneliness is much more concerning, that concept, I just don't feel connected. And even more so, I don't feel anyone wants to connect with me. I think that's where I don't recall getting a lot of psychotherapy training and working with loneliness, but I think that's where I've been spending a lot more time thinking about those things. And then lastly, answering a lot of questions about COVID-19. And, as a physician, people want to know, is this safe? Is this not safe? And even as a psychiatrist, I think it's I had to put a lot of time and effort into understanding what our practices are and aren't. So that's some reflections of the things that I've been going through. I want to emphasize what I think providers should be doing as a task list during COVID-19 to make sure mental health impacts are addressed. And it starts with guns and weapons. More people are buying guns. More people are thinking about guns. And obviously guns are the number one methodology of suicide completion. About 50% of suicides, of course, are from firearms. So that means we as providers need to do a better job of not only asking about guns, but asking about who else owns guns and who else, what other guns and weapons they have access to. I had a client who at the start of the pandemic wasn't a gun person, but he went out and bought a spear, like an actual boar spear. And he said it's easy to use, but I said that's still a deadly weapon. I had grave concerns about a spear being housed inside the home where there were children. So just an interesting area. Prescription pill management and disposal is critical. And this doesn't have to be the lane of physicians. I think too often than not, I think a lot of therapists don't do this, where they say, do you have any expired prescription pills? And if you do, this is how you should get rid of it. Or do you have any prescriptions currently that are controlled substances by your doctor? And if you do, how are you managing their safety in your home? How are you ensuring, because everyone's home now, that no one else gets to those prescription medications? So I think that's an important part that needs to be brought up. And then really, I find myself, and I think it is important to talk with clients at some point about their COVID management plan. Should that happen to them or to their family members? Because to reduce the stress of COVID, by having a management plan, I found makes a huge difference. So too often we've seen the COVID create the anxiety, create the depression, create the substance use. But in part, much of that can be managed if people knew, well, if I did contract it, what am I going to do? How am I going to manage? How am I going to survive? What are the first things I'm going to do? And I think that's important. And of course, connecting people back to their general healthcare providers to stay healthy. All right, so let's leave the mental health aspects. And I want to tell what do we know about how COVID's impacted addictive disorders and what should we know as a roadmap moving forward. So first, number one, it's clear. The data has already come in convincingly. It's COVID-19 has increased the incidence and prevalence of all SUDs across the board. Alcohol, tobacco, cannabis, opioids, stimulants, you name it. And the reasons are obvious, right? Physical, emotional stress, the rise in depression, anxiety, ADHD, trauma, availability and access of substances that have not gone down. Within March, alcohol, tobacco, cannabis in the state of California were all deemed essential, all via a delivery model. So availability and access did not go down, it went up. Lack of prevention treatment programs, not being able to come online, and just not having nearly as many options, for people to go. And when you don't have your usual standard coping outlets, the exercise, the movies, the sporting events, of course, all of that. All of this makes sense. We know that. And we know that as the pandemic continues over the next year or 2 years, this will continue. So the idea is, how do we get in front of that and how do we reduce some of that? The second major part, of course, is just having a substance use disorder will increase your risk of developing complications from COVID. So it's bidirectional. If you have COVID, you're going to use more substances and increase your risk of developing addiction. If you have COVID, if you have substance use disorder, if you catch COVID, unfortunately, your risk of developing complications go up. Why? Because you're more than likely, compared to the general population, to have medical co-occurring problems. Alcohol, kidney, lung problems, asthma. You're less likely to have access to healthcare. And here's an area where it may actually be longer for you to heal. So you think about all the physical damage of substances over years, it impacts wound healing, it impacts immune system. So all that we know to be true. But the other part is men and women with substance use disorder have profound sleeping problems. And when you have sleeping problems, that also means you're more likely to develop stress and difficulties with fighting off infection. So the end result of that all is, again, emphasizing to our men and women with substance use disorder all the more reason why they need to get more aggressive and accelerate their recovery work in order to prevent the COVID complications. Here's an example of a study that highlights this and documents this, talking about, again, lung function, like COPD, puts people at risk for developing complications of COVID. So if you smoke, clearly that's going to accelerate all of these things. NIDA, our National Institute on Drug Abuse, put this out recently, some researchers about a month ago, about COVID-19 risk and outcomes in patients with substance use disorder. Essentially, they took electronic health records in the United States and really wanted to look at all the impact for men and women with substance use disorder. And not surprisingly, by analyzing it, they found that all the records, about 11% of the men and women with COVID-19 had a substance use disorder, that 15.6% of all the cases they had. So again, investigators found that while 10% of the electronic health record patients had substance use disorder, that those with substance use disorder represented a disproportionate number. So unfortunately, the data is starting to show us this, and we know over the next 6 to 12 months that it will continue to get worse and worse and worse. It would drive down why. Again, we mentioned alcohol. Sales went up immediately in March. The bars closed, but sales still went up because of delivery services, because of the ability for people to still go into stores like Costco and buy large volumes of alcohol. I highlight here because, again, as a reminder, the alcohol use spectrum goes from use to excessive to alcohol use disorder. And it doesn't happen overnight. That it still takes several months to develop an alcohol use disorder. And that it doesn't happen in just one weekend of heavy alcohol or excessive use. All the more reason for us to constantly be on our patients to talk about proper and recommended alcohol use. So as an example, data show that here alcohol consumption during the pandemic has increased by 14%, and for women 17%, according to a recent report. And also even more heavy drinking, which is defined as a single drinking occasion of more than 4 a day for a woman or 5 a day for a man. Heavy drinking doesn't mean alcohol use disorder, but it's concerning. So our goals with our clients are very clear. Reduce heavy drinking, meaning less frequent, less often. Again, recommend the standard or healthier amounts that are recommended, which is 1 drink a day for a woman and 2 standard drinks a day for a man. Again, people will argue, oh my gosh, give me something during the pandemic. What else am I going to do? Well, we highlight, well, does the idea of drinking more, which we know is not good for your body, brain, and mind, does that really sound like a good trade-off in exchange for a very short period of emotional response from alcohol? Not really. All right. Cannabis and COVID. So in March 2020, the recreational sales plundered in California, in part because everyone was shut in and no one wanted to go. And although the dispensaries were still open, even the delivery service, people did not want to get a delivery of cannabis for fear of getting COVID. But then stimulus checks happened, people started settling in, and sales rebounded in California. What's interesting in California now, all the dispensaries are still open, all the delivery services are still open, and what we're finding is that people are spending more money per visit to recreational retail, but going less often. So in other words, they're stocking up. So they're going in on a dispensary, and instead of buying maybe a quarter ounce, they're buying the full ounce. And again, that has implications. When you bring that back to the home, more people are going to try. You might end up using more because it's there, and that's something we're concerned about. When it comes to opiates, unfortunately, the story is, as predicted, really tragic. More overdose deaths, not less. Compared to 2019, CDC numbers are estimating by the end of this year we'll have 75,000 deaths that were related to opioid overdose. So that doesn't mean they just died from opioids. They died and their opioids were involved. So opioids plus alcohol, opioids plus benzos, opioids plus antidepressants. So again, that's a 5% number in that death. By this time next year, unfortunately, I think we're going to still see that again. That's going to continue to run unabated. Again, why? More available, easily there, drug prices going down, hasn't stopped, lack of access to methadone clinics, lack of access to treatments. When it comes to stimulants, cocaine, amphetamine predominantly, what we've heard from the street is that drug prices have plundered, in part because a lot of cartels and dealers just had too much supply in the beginning. However, when people, as the pandemic continues, I foresee, as people getting less income, disposable income, they're probably less likely to use the fancy, expensive drugs, and will probably go down to buy drugs that are in lower purity or are much cheaper and easily available. And unfortunately, that's a perfect setup for methamphetamine. Here in Los Angeles, methamphetamine remains incredibly available, incredibly potent, and incredibly cheap. A quarter bag or a small bag that they get for $20. And you can use multiple administrations of meth from just $20 of work. So we know that's something for us to look at. Tobacco use and vaping, again, if a global surveys show increased sales, but curiously also increased interest by people stuck at home wanting to quit. And that makes sense because when you hear constantly in the news, COVID, respiratory complications, if you're a smoker, you really need to stop smoking because that could then protect your risk from developing COVID complication. I think that's the line we're thinking. So we really have to as providers, take advantage of that and do more for tobacco cessation. Video games, and I'm really excited to hear about Evergreen putting out a whole new digital gaming track for education and support. This is just data taken from the video game manufacturers highlighting that compared to last year, every month has seen spectacular growth in sales of video games, a 25, 30, 40% increase in revenue compared to a year ago. That's staggering. No other business can claim that. So again, just something to think about. How does video games impact people's lives? Unfortunately, we do know for a small percentage of people, it develops addictions, and problematic use, no different than gambling, and something for us as providers to talk about and discuss and think about. All right, so let me turn to how gambling impacted, kind of COVID impacted our gambling programs in our state, and how it's impacted gambling treatment. Well, much like your timeline, when we had our last live symposium on gambling disorder, it was 4 days before the pandemic broke. And I remember looking around thinking, I don't know if we should do this, but we did it. We had 120 people there. I've not been to a live event since then. We went to Safer at Home in March. Casinos shut down, sports shut down, everything went to telehealth. Summer 2020, the casinos started to return. And I use that parentheses awkwardly because it was plexiglass. There was hand sanitizers. There was outdoor gaming in a parking lot. There was moving slot machines to the outdoor. And just, again, a very different style. But again, the demand was definitely there. And of course, we're all working from home. On the treatment side, COVID had a massive impact. Shut down our residential program for nearly 2.5 months. They've reopened, but only at half capacity. And again, the treatments provided are not nearly as much in person. There are masks, social distancing, no hugging, no hand holding, none of that powerful connection stuff that used to happen. Intensive outpatient is all digital. Outpatient is a fascinating mixture of digital, and some still do people in person if they so had the proclivity, and as well as by phone. Telephone helpline services obviously remain intact, but calls for the first few months dwindled massively. Now we're seeing a return in some calls to the helpline a little bit more, but still not what they were about a year ago. And all trainings like this and all supervision completely 100% virtual, which is fine for now. But what happens a year from now, or 2 years from now, or 5 years from now? One of the great values I get from conferences like this is just spending time at the break, learning about people's new programs, answering questions, asking questions, and learning about what's happening in the local. You can't replicate that in any forum. I know you have a networking event after this, but there's still nothing like giving someone's business card and then building a relationship from that. So some of the guidance I would highlight here, I'm going to skip this, because immediately what I saw is what are the clinical issues that COVID impacts our work with gambling disorder clients. And it started with right away this idea that, bang, in March and April, we were going to get a natural experiment of gambling withdrawal. That if gamblers couldn't go, then we're going to see gambling withdrawal through the roof. And we really didn't see that. Not that I don't think it doesn't exist. I think it just highlights that I think the shock and awe of the pandemic superseded anyone's actual withdrawal symptom. But that's still an option that's out there. Number two, obviously, with the quarantine, there was extreme concern on our parts that ADHD co-occurring gambling disorder clients would actually have a much, much harder time at home. And that's borne out to a degree. I think the idea that that comes to mind, again, if you're working with a client that's really struggling and maybe they're not sleeping, there's a lot of conflict at home, or maybe they're not making a lot of progress, that may be why. It may be ADD that's just not adequately treated during the COVID time. And again, I found myself spending a lot more time talking about online lending, particularly with a lot of gamblers who said, well, I've maxed out my credit cards, my paycheck has stopped, my disability hasn't come in, my unemployment hasn't come in, and the tendency while you're at home to seek out online loans, which unfortunately, some of them are quite predatory and quite expensive in terms of interest. So again, that's an issue for us as providers to think about, to educate clients about. But let me skip that part, because I also thought about things that I saw right away as things I had never talked about before with gamblers. And I found myself talking more and more about how to improve connection at home through pets. And a number of the clients I had during the pandemic, they were able to secure pets from shelters or other areas, and it was absolutely profound in terms of its impact on recovery and improving recovery. But also talking again a lot with gamblers about just the heaviness of the news and of the pandemic, and being okay with using precious time in therapy to process the pandemic together with the gamblers. Let me skip that for a second. I want to go back to what I think is most critical about what I think providers, as we move forward with our virtual office, what I would call kind of the COVID-19 toolkit. So it starts with preparing your virtual office with the best technology. We're fortunate at UCLA, we have incredible internet speeds that are hardwired, it never drops. That's not always true for a lot of private practice folks. And high-speed internet and high-quality internet is expensive. I found, at least in our home, when we switched to what's called a mesh router, and it's a couple $100, but that allowed me to have profoundly superior internet speeds that really has no lag. So that's number one. Number two, the concept of reducing distractions. I've learned now, and it's taken me several months, as we all have, how do I do sessions from home, or how do I limit distractions even at work? So for me, I have a double monitor. That means I have to turn off that second monitor. I can't have, Twitter on while I'm doing therapy. If I've also now made it a policy for not to do virtual office visits from home. And it's just a personal thing. I'm not comfortable with people seeing the background, and I'm not comfortable with using a virtual background with clients. And I'm fortunate to have a lot of space here at UCLA. And one of the things that's interesting, we have a lot of clients still doing sessions from the road, and I've seen that now. I've had several clients call in for a session and they're driving, and that begs the question: what do we do? Do we say to them, stop the session, or do we say, let's keep going? I've had clients call me from their offices while they're working. I've had clients call me. I had one client, who called me from the golf course while they were playing. And these are all shocking things, but it brings back to us as providers to say, during the time of COVID, we have to talk about boundaries. We have to talk about policies. And we have to talk about what we're comfortable with and not comfortable with. So as an example, with a new patient, I'll say this: I'll send an email or I'll send a text saying we're scheduled for 10 o'clock. Please make sure you're in a secure, quiet place and can talk uninterrupted. The ninth hole doesn't count. So that's an example where sometimes you have to say those things because people are just going to be people. But other things that I've learned from the COVID toolkit is we need better standards of practice for telehealth. When I go to my parent association standard, the Medical Board of California, I say, what are the standards in terms of documentation, confidentiality, security, time spent, all these things? It's still evolving, and I think we need to eventually build some of those things. I very much like using the shared screen feature. So what I'll do, I'll share screen and then I'll type out the lessons of the day, or type out the main key points. Or I'll say, here are the 5 tasks I'd like you to do before our next visit. Or here are our medication changes. And patients said to me they really value that feature because now they have something in writing. I then can take that, what I wrote, I pop it into my electronic record, and suddenly I have a lot of really great information moving forward. I've also found that I struggle with the 60-minute session. So I'm now deliberately stated to patients I can only do 45 minutes max, because otherwise I'm not providing good service to you. And a lot of what we do is working that language to patients now about alcohol and tobacco and exercise and sleep. And another way of reducing resistance is to say that these are the way to strengthen your body's defenses in COVID. And I think that's really given people a lot more wow and a lot more inspiration to do things that they may have been resistant to do in the past. I've often find this idea of, I don't like saying, I want you to find structure, or I want you to find a sense of purpose. I found that, for me at least, that I don't find that effective, and I feel it's a little too abstract for patients. And I like instead saying, let's focus on how you can build up your sense of being useful. And I found during the beginning of the pandemic, what helped me with knowing that I was being useful to someone, either patients or my family or my friends, or even people in need. So even volunteering and handing out food, that helped me feel useful. So I like to use that language of usefulness instead of structure and purpose. And that way you can be useful at home, you can be useful while you're quarantining even, or you can be useful going back into the community and engaging. And again, the phrase is integration, not separation. The language that I'm using with providers and with patients is that, you know what? There is no new normal. This is our current life, but let's integrate our lives better and not isolate and separate. I saw a cartoon the other day. It was so great. It says, I don't work to live now. I live at work. And it was a picture of someone working at home. But our lives are completely integrated now. Work, life, home, family, school, relationships, all housed in a single building. And I think that's integration. And the real task is how do we still do that properly so we don't get overconsumed. All right, so with that, let me turn to the audience for a few comments and questions. A couple of things here. That is my email. Should you have questions, ideas, thoughts, other things from this the field you want to share. My Twitter handle is there. I'm slowly building that up. And there's our website for our gambling program where you can access a number of our gambling research tools and strategies and just information of what we're doing in California. So let me hold there and turn to the chat to see if we have any chats and questions of interest. All right. They're pretty wrapped up in the origami. I'd love to see some of the origami products. So here's one about COVID bringing meaningful messages, although it's frozen our daily activities. We can talk with clients, et cetera, morality and materialism. I think that's, again, very, very well said. One of the things I've also been highlighting, people would say, well, how do you stop yourself from being burned out? How do you keep going? And I think that goes back to, at least for me, having a profound sense of usefulness that I feel really good about. So knowing that I feel useful for patients, knowing that I feel useful to UCLA, knowing that I need to be useful for the family, that drives me and keeps it all up. I do get exhausted with the Zoom and the digital lifestyle of that. And so on a typical day, it'll be basically 8 a.m. to about 3 or 4 back to back. That's frustrating. I'm trying to be better at taking an hour for lunch. And I'm trying to be better about shortening those meetings. And oftentimes we have lab meetings instead of an hour to bring those down to 30 minutes. I think those are really tough. The other thing I encourage people to think about are blue light glasses. I got those for the kids, and that seems to really help with reducing screen fatigue and eye strain. And I think that's really good. I just don't wear them with patients. I'm a little vain about wearing glasses, but that's what we have there. So those are some other tidbits from the field of what we're seeing here. I certainly hope to be in touch with everyone moving forward. And if there's any other questions or comments, don't be shy. I see Maureen has a excellent long thing here about next November. You're going to be talking about service members and their loved ones, sessions on prevention, treatment, and recovery for active military veterans and families. So that's super cool. So we'll definitely look forward to that.
Hey, Tim, it's Maureen. Can you help us, since you are wearing so many hats? You're an MD, you run the UCLA Gambling Studies program, you work on cannabis issues, you work on all sorts of co-occurring disorders. What are some tips you might have to help make sure that primary care folks or ER rooms during this period are clearly they're dealing with some very important issues, but when it starts to come to mental health issues, are there ways to help tie in that partnership with counselors and treatment providers for referrals?
Yeah, I think that takes a lot of work, but it has to be done. So I recognize it's not normally their lane in primary care, and now it's become their lane. So what I'd say to my primary care colleagues here at UCLA, I'll say, you know what? Think about having just a mental health checkup that's separate from the physical checkup. And when I bring that idea to them, they oftentimes are struck. They go, what do you mean? So I say, well, maybe on Monday, you're going to talk to them and about their physical. Maybe next Monday, you schedule them when you would never have normally scheduled them and talk just about mental health for 15, 20 minutes and about the importance of not drinking heavily and the importance of stopping smoking. I think oftentimes primary care docs and allied healthcare professionals forget the power we have by a firm statement saying during this very stressful time, you should not engage in excessive drinking. That is only going to lead to problems. You should very much look at strengthening your body's defenses from if you get sick. I'm looking at you and I see the best way you can do that is by losing weight, by smoking less or not smoking at all, and by getting a little bit more sleep. So the message to primary care is that we now have these mental health tools and these strategies that would actually better outpatient. The other part is we have to do better at seamless referrals. We're fortunate at UCLA that we have a closed electronic record system so that when they want to refer someone from, say, internal medicine to addiction, that they can just do an addiction consult order. But many people don't live in a closed system. Like if you're in the Kaiser or the VA, these are all closed health systems. But if you're in the county, it's not. So all those systems are going to be widely separate and diverse. So I think we have to do better at getting shared information that's easily understood and easily available and easily accessible. So I think that means, again, sharing information with helplines. I think that, again, means people using the power of social media to push things out more frequently and say, did you know this clinic here is now accepting new patients with very limited wait times? I mean, those are the things that gets out there. And then lastly, it's, again, building those consortiums that meet regularly. One of the consortiums I sit on is a task force to work with men and women who are hospitalized from cannabis-induced lung injuries. We have standing regular meetings, and not everyone shows up, but we know that every fourth Thursday at 12 is a meeting on cannabis and pulmonary problems. And that's just a standing meeting, and more people come, and we keep pushing information out and get it to the right people. So just a few things, but I think it always goes back to a lot of this is just marketing ourselves better and not being shy of telling people what we do, telling people what our capabilities are, and letting people know we're open for business. I think that's very important.
Wonderful. Thank you so much, Tim. I imagine there will be other questions that will come from folks, but this was a great presentation. We appreciate it.
Thank you so much. I'll talk to you later.
Bye.
Bye.